Hello, everybody. I hope you can all hear me. Thank you for joining us tonight for this webinar about diabetes research. My name is Jim White. I'm a journalist and broadcaster, and I was diagnosed with type 1 diabetes in 2001. And I've been a guinea pig in several research projects over the past few years. And the good news is, for those concerned what it might involve, I'm still here. A big thank you for the excellent questions you've already sent in. If you want to ask a question during the event, please post it in the Q&A box. It's the little speech bubble at the bottom right of your screen, and we'll do our best to get around to answering it. To change how the speakers appear, click the 3 buttons at the bottom of the screen next to your red phone icon, then change layout and select the sidebar or spotlight setting. So that's sidebar or spotlight, and it basically try it out and see which you prefer. Unfortunately, we won't be able to answer any questions about individual cases. So if you have got a worry, please talk to a healthcare professional about that. Tonight's being recorded, and you'll be sent a copy of the recording. And this event has been organised by the National Institute for Health and Care Research, or as it will be known throughout this webinar, the NIHR. The NIHR is a government-funded body that funds research in the NHS, public health and social care. If you're interested in learning more about research and maybe to search for the studies you could take part in, then please visit the Be Part of Research website. Just search Be Part of Research. And remember, you can take part in many studies, even if you don't have a health condition yourself. I'm delighted to be joined by 2 real experts in this field, Dr. Liz Morris and Dr. Rustam. And they know far more about themselves than I do. So I'm going to invite them to introduce themselves. Liz, kick us off. Tell us all about yourself.
Hi, good evening, everyone, and thanks so much for joining us. As Jim has said, my name's Liz Morris. I'm a GP working in Oxfordshire. And as a GP, I meet people with diabetes from the very first day that they get diagnosed, some of them in my clinic room, through to people that have lived with this condition for many years. The research that I help to run is trying to answer the 3 main questions that my patients ask me during these encounters. And on that first day of being diagnosed, particularly with type 2 diabetes, I'm often asked, how much weight do I need to lose today? What diet should I follow? And what changes should I make when I leave your consulting room today? And is this it? Do I have this condition forever now? Or is there anything I can do to change this? And so really, my research is driven by the questions that my patients are asking me. And we hope we're working towards answering them.
And Dr. Rustam, tell us all about yourself and your involvement in research.
Thank you, Jim, and thank you to everyone who's joined us this evening. It's great to see you. So as Jim said, my name is Rustam. I'm a diabetes consultant in Oxford. I've been here for nearly 10 years now. And like Liz, I'm really active in research, and it's driven because of the people with diabetes who I see in my clinics every day. My interest in research is mostly in people with type 1 diabetes. And so we're interested in technology research. We're interested in research looking at different types of insulins, and we're interested in research that will help people to live better with diabetes. So lots of clinical work, lots of research, and lots of exciting things to talk about this evening.
Well, thank you very much, Rustam and Liz. I think we're in safe hands. Let's crack straight on and ask some of the questions that you've already sent in. I think this is a fundamental, and I'm going to throw it to Liz. Liz, is diabetes reversible? And if so, how?
Well, thanks, Jim. That's a brilliant question to start with. And it's a really exciting one because it's one where research that people with type 1 and type 2 diabetes have been taking part in and have really changed our understanding of and changed the lives of people with diabetes in the recent decades. So I think when we're talking through all of these questions tonight, it's going to be really important that we think about when we're talking to people and about people with type 1 diabetes and type 2 diabetes. When we talk about diabetes reversibility, we tend to use the term remission, and that means people with diabetes achieving blood glucose levels that are below the range that we would diagnose diabetes at, and maintaining them, so keeping lower blood glucose levels without needing medication. So at the moment, unfortunately, it's not possible for people with type 1 diabetes to put their diabetes into remission, so to reverse their diabetes, although that is something that research scientists are working really hard to understand even how it might be possible in the years to come. For people with type 2 diabetes, newer research studies have shown us that it is possible to put their diabetes into remission, so to achieve normal or lower blood glucose levels without needing medications. The strongest evidence that we have from studies, particularly that looked at bariatric surgery, so obesity surgery, and more recently in the last 5 to 10 years, looking at low energy diets. So that's really cutting down your energy intake with really intense support from healthcare professionals alongside, that can help people to lose the substantial amount of weight that they would need to lose, particularly if they live with overweight or obesity alongside their diabetes. And that's the strongest evidence we have of the best way for these people to put their diabetes into remission. But it's a growing field, and something where there's still a lot more to know and a lot more to learn in the years to come.
Rustam, I think this one's for you. Our questioner says, I've had type 1 diabetes for more than 22 years. I lead a very healthy lifestyle, have a normal range BMI, and I'm very fit and active. My life is consumed with diabetes management. Now, the issue is, if you get involved in research, does that make you put your condition slap bang in the center of your life and actually make it even more of a pain in the neck?
Oh, a great question, Jim. And it's really important to recognize that when you're living with diabetes, be it type 1 diabetes, be it type 2 diabetes, it can play can put such a huge stress and a huge burden on your life. And I think that's something that when we talk to people with diabetes, we hear this a lot. So there's a couple of things I wanted to talk about. One was there are different ways now through the research that we've done over the last few years about trying to take some of the burden off people who've got diabetes. So the questioner's got type 1 diabetes, and some of the things, particularly around the technology aspects. So using some of the new sensors that have been developed through research, using some of the new closed loop systems, whereby a sensor senses what your blood sugar is. It then tells a little insulin pump how much insulin to give, and you get that automatic feedback system. So you get what's called a closed loop. And for some people, that combination of technologies takes a lot of the burden of the everyday managing of their diabetes off them. For other people, it just adds to the burden because they're worried about whether or not the technology is going to work, or whether it's going to break down, or whether it's going to fail. And so there are other studies looking at how we can take some of that burden off people. So how, rather than being afraid of their diabetes, rather than being consumed by the diabetes, they can learn to live with it in a more holistic way. And so I suppose I'd split those two bits up into research around technology, but also around support and help and self-management, and getting that, just taking that burden off people.
You mentioned there the closed loop system, and we've got a question here from one of our attendees tonight. I'll put it to Liz, because you actually are someone who prescribes diabetes things. And how long do you think it will take for type 1 diabetics to be given closed looping technology routinely? How far off are we from that?
That's a tricky question, Jim, and I know it's one that's really important to a lot of our patients with type 1 diabetes. So working in primary care at the moment, it's not something that we have access to prescribing. This is really specialist technology still, and only available in certain settings. But I know that Rustam will have more experience with that, working in the hospital in the specialist setting, supporting people with type 1 diabetes there.
Yeah, I think that's right, Liz. And I think we're really keen to roll out this technology to people with diabetes. The research has shown that when you provide people who are educated in the technology, who understand the technology, they can deliver some really fantastic results. I'm sure many people have heard about something called the HbA1c, but there's also another metric that we use, another measure of good diabetes control, and that's the length of time you spend with a blood sugar between 4 and 10. And usually if you have a good HbA1c, you'll spend around 60 to 70% of your time in between those two values. But we know that with closed loop technology, the research has shown that you can get up to 80 or even 90% of your time, which means you're spending less time low and less time high. And so the research is really driving this forward, and that's driving organizations like NICE, who recently published a technology appraisal looking at the sensors and the pumps. And next year, they're going to publish a technology appraisal, which is just a fancy word for saying, this is what we think is really good value for the NHS in closed loops. So be patient, but that's where we're hoping that will come through. And then hopefully that will then translate into more and more people getting some of these technologies and some of this closed loop that the research has shown is really effective.
The question is, though, Rustam, how long do you think it's going to be? I've been diagnosed for 20 odd years, and it seems to me it's always 5 years away. The great leap forward is always 5 years away. So where are we with this? I mean, how soon will it be?
So it's a good thought, Jim. When I started looking after and helping people with type 1 diabetes about 15 years ago, we had very few people on insulin pumps, and we had absolutely nobody on closed loop systems. I think in the last 5 years, we've seen a massive shift. We've seen a huge increase in the number of closed loop systems, which have shown the research, which have shown really good control. And we've now got 3 or 4 on the market that we've probably got in Oxfordshire around 40 to 50 people using. We didn't have any of that at all 5 years ago. So I think in the next couple of years, we'll see a real exponential growth in that demand, and hopefully in that ability for people to manage their diabetes really, really well.
But Liz, we've got a follow-up question from our attendees tonight, which is about CGMs, which are closed glucose monitoring systems, continuous glucose monitoring systems. They tend to be things that people with type 1 diabetes use. How far off are we getting people with type 2 diabetes to check their blood glucose via these systems?
So I think, as Rustam has alluded to and has mentioned, there's real benefits to be had potentially for people with these newer technologies like the CGM, the continuous monitoring. But we've also got to be really mindful that we're not just shifting the burden to the person living with diabetes and away from the healthcare professionals being able to help them. The historic research studies that we have, going back to when people were having to do their finger prick testing for blood glucose levels alone, actually showed that for people with type 2 diabetes who weren't using insulin, it didn't massively help them to have really frequent readings of their blood glucose levels, because they didn't necessarily have something they could do there and then in that moment about it. So they were getting the stress of knowing the high levels without being able to do something about it. There is newer research evidence now looking at these CGM monitors, so the continuous monitors rather than the finger prick testing, that shows for people particularly using insulin that there are benefits there for people, not just in terms of the blood glucose levels we as clinicians might look at, but outcomes that are really important to the patients themselves. So the feelings of control or diabetes related distress. So the research is starting to prove a need or a benefit, certainly for some people with type 2 diabetes there. That really then leads on to a question of availability, as you said, when are we going to see it? And some of that does come down to cost to the NHS, and so different areas have different ways of appraising the information we get given and that comes up from research. Rustam mentioned the NICE guidance, the Institute for Clinical Excellence. They give guidance to different areas about what we should have available and what might be beneficial. But at the moment, I'm afraid it's still down to different areas of the country working out how many people they can offer them to. But really the crucial thing there is going to be the research studies that prove what benefit people with type 2 diabetes get. And obviously if there are benefits to be had, that's something that we want as many of our patients as possible to have access to.
Rustam, I think this question basically gets to the heart of what you do and what this evening is about. And it says this: why should we, as people with diabetes, get involved in research just so that Big Pharma can make even more money out of our condition?
Oh, that's a really great question. And the honest answer is, if it was all about Big Pharma making lots of money, I wouldn't be here, you wouldn't be here, and none of us would be on this call. It's not about Big Pharma making money. For me, it's about making people with diabetes, their lives better. And we won't know which drugs will do that. We won't know which technology will do that unless we do the studies. What we're trying to do is to work with Big Pharma to make trials shorter, quicker, cheaper to run, and therefore the drugs will be cheaper when they come on the market. So although Big Pharma can be seen as the sort of the bad person in the room, and what we really want to do is to do trials without Big Pharma, what we're trying to do is to work with Big Pharma, not so that they can make large profits, but that so we can get the drugs that will help people with diabetes to the market quicker and cheaper and more effectively. Hopefully that answers the question.
It certainly does. Here's another good question. I'm going to throw this to you, Liz. I'm involved in research already, but I still find it hard to find research to get involved in. Is there a website where you can pick your condition and it gives you all the current projects and where researchers can log in and list research projects? That is a really fundamental question, because I know my involvement in research has tended to be through my diabetic nurse saying to me, oh, are you available to do this? And I don't really have a choice in that. I can either say yes or no, but I can't look to the research that might be better for me or more beneficial for me.
So it's so lovely to hear that we've got people really enthusiastic and committed to seeking out involvement in research, and we're really incredibly grateful for that. The short answer is yes, Jim, such a thing does exist. It's a great idea from the person that's put it forward, and thankfully someone has thought of that. So if you type in your search engine, Google or other search engine of choice, be part of research, that's be part of research, you'll find the NIHR, National Institute of Health Research website, which does exactly that. You can see a list of really accredited research studies that are running, find out more about them, and there is even a search function, so you can search either by region of the country if you're looking for something closer to you, or by condition to find one that might be more relevant, and you can express interest and be connected with the researchers and the research studies through that website. And that link, I know that the team from NIHR who are running this webinar will send that out to everyone that's registered in the coming weeks.
You just mentioned there, you can seek out one that's close to you. Do you have to be close to a research project, or could you do one, you lived in Plymouth and it was up in Carlisle? I mean, or do you have to be close by so you go in and are seen face to face?
So that will depend on the research studies. There are many that recruit across different continents, different countries, and certainly lots that recruit across the UK. There will be a few, maybe smaller studies that require more intensive trips into a local hospital, where they'll tend to recruit just from their local area to reduce the burden on people. But all of this information is visible on the website when you're looking. And there's lots of studies where you don't just have to be close by to the research centre. And particularly now, research processes have changed a lot during COVID, and there's a lot more being done online to try and reduce the amount that people have to travel to be involved in research, and also reduce some of that burden and improve the access to lots more people across the country who'd like to be part of it, like to be part of making a difference, but couldn't just do it if it had to be in their own local area.
Rustam, I think this one's for you. How many people do you need every year to get involved in research?
Oh, great question, Jim. I'm just going to pick up on Liz's point, actually, which will answer your question as well. We're just about to start a new research study in people with type 2 diabetes. And actually, this study is going to hopefully going to recruit 20,000 people across the UK. But the beauty of the study is that you don't all have to come to Oxford. In fact, it's 20,000 people across the whole of the UK, and a lot of the consent processes, a lot of the talking about the study and deciding whether or not to do it will be done either on the telephone or online. So with the option of going and seeing somebody if you want to. So it's a really exciting way of doing research. Hopefully it will allow lots of people across the country to take part in it. So there's some really big studies looking at 20,000 people. In Oxford, we've got a study every year. We need around 600 people to take part in research. But also there are studies looking at, less than maybe 4 or 5 people in each site. Across the country, there might be half a dozen sites. So there might be something around 20, 30, 40 people in the country. But each site might just be recruiting 4 or 5 people with diabetes.
Okay, Liz, so we've signed up. We're going to be involved in research. It may take a year of our lives doing this research. Here's a really good question from somebody before this event, how can research participants find out about the results that they've been involved in? Because generally they go into medical journals that we can't access.
That's a really, really important point, and thank you to whoever answered the question. It's really important to us as researchers and as clinicians as well, that the people that have given up their time, as you say, sometimes a year of their life, do find out the answers. And there are lots of different ways. The first one I would say is, if you've been part of a research study, you'll have the contact details of the team that were running it. And everyone should feel empowered and able to contact the people you've been in touch with as part of the study and say, I'd like you to send me the results when they're out, and they'd be more than willing to do that. Most research studies and research units will have a website for the particular trial or study they're doing, where at the end of the process, and you're right, it can feel a really long time for when you've signed up, because it's not just the year of your life, but everyone else's years added up as well. And it can sometimes be 2, 3, even more years before the results are known. It's the team's responsibility, and everyone has to do this as part of reporting as well as wanting to put the results up on their study websites or on reporting websites. So I'd say, ask, if you're involved in research, ask the people that you've been working with, have been working with you, and they will send you a copy. If not, go back and look at the study website. And there are other more sort of central resources if it's a study you've not been a part of, but you're still really interested in. Some of the charities that work with people with diabetes, for example, Diabetes UK, will often report on the latest studies and findings relevant to people with diabetes and make them accessible. And the Be Part of Research website from the NIHR has experiences of people that have taken part in research, and does also link to reporting studies that have gone. So hopefully between all of those ways, there's good, accessible, clear ways for people to find out the results of the studies that might be relevant to them.
Rustam, I know the research projects that I've been involved in, it's been new types of insulin, it's been new types of checking your blood glucose levels and so on. I think this is a really fundamental question we've got here. When will cure-based type 1 research projects, including those for patients who've had type 1 for many years, be prioritized over simply managing the condition?
Oh yeah, that really gets to the heart of things, isn't it? We don't just want to live with diabetes, we want to get rid of it ultimately, don't we? So if we think of this as sort of our life's journey, the ideal would be to prevent diabetes in the first place. And Liz has talked about how we can put type 2 diabetes back into remission based on some fantastic studies across the UK over the last few years. In terms of type 1 diabetes, there's a new study that's just starting at the moment, looking at young children, measuring their risk and whether or not they're likely to get type 1 diabetes, and then starting some treatment to try and reduce that risk of them getting diabetes at all. And some of those studies are looking at a sort of oral formulation of insulin, but there are other types of drugs that we're looking at to see whether or not they can change the risk of you getting type 1 diabetes in the first place. So there's something about preventing the diabetes, and there's lots of research going into that particular immunotherapy as well. We've talked about the technology, which doesn't get rid of the diabetes, but hopefully reduces the burden. The other key part of research has been around what would happen if we were to give you your pancreas back. Now, it wouldn't be your own pancreas, it might be somebody else's, or it might be those cells that produce insulin from someone else. And so in Oxford, there's a huge amount of research going on to say, can we purify or can we manufacture what's called islet cells, these little cells in the body and the pancreas that produce the insulin? Can we put them into people who have type 1 diabetes, and can we get rid of their diabetes altogether? What usually happens is we get rid of their fluctuations. And for some people, it means they don't have to take any insulin. But for some people, and we don't quite know why, some people respond in that way, and others still need to take a little bit of insulin, but usually a lot less. And then the third aspect would be a different form of transplant. So this would be a pancreas transplant. So a whole pancreas is transplanted, which is obviously a bigger operation than just a few islet cells, but that tends to be more successful in making people not have diabetes afterwards. So lots of research taking part to prevent the diabetes, to try and simplify the management, but then also to try and get rid of the diabetes altogether using some replacement therapies.
Interesting question here from one of our participants tonight. I'd like to ask, I'm going to put this to Liz, I'd like to ask how doing research, running studies and having clinical staff who do research benefits healthcare teams and the diabetes services they provide, particularly in comparison to teams and hospitals who don't do research? Are you better at doing your job for being involved in research, is what I think he's asking.
Well, that's a great question there, and I think we'd all like to hope that we do the very best at our job, whether we're solely clinical focused, solely research focused, or like Rustam and myself, and try and do both. I think it's a real privilege to be a clinician, and it's a real privilege to work in research, and that's certainly been my experience. And I find that personally, and those I see around me, there's a real synergy. It's really complementary. It allows you the time and the ability to go away and try and answer some of these questions that your patients are putting to you in real time, and try and bring back an answer to them or to the next generation of patients. So I think it really does help inspire you as a clinician, and hopefully allow you genuinely day to day to bring back more to your patients from these other areas of expertise that you have. I think it's really fortunate if you work within a team where there is research capacity. We know that healthcare systems and resources are really stretched and under pressure at the moment. And so having that time and space to, whether it's spending time with the research participants in a slightly different way and patients in a different way, I think can be really beneficial. But the wonderful thing about having a research network like the NIHR, the National Institute of Health Research, is that we're trying to translate those benefits from the centres that are lucky enough, fortunate enough to be doing the research directly and quickly across to those centres that aren't, so that the learning, the processes, the knowledge that we gain from working with people with diabetes and doing the research studies can really quickly be felt by people and healthcare professionals in centres that don't have research. So I think, as a personal story, I can really feel the benefits, and I really hope some of my patients do too. But I hope that the national infrastructure that we have is trying to minimise discrepancies and differences between areas of the country that do and don't have access to that.
I think we clearly, despite the interest of one of our attendees today, who says, do we know of any closed loop research that's going on at the moment? Before I ask Rustam if he does, earlier in the chat, if you go back, Oliver Evans has put a link to the Be Part of Research website that we were talking about. Maybe you might be able to find it there. But Rustam, do you know of any closed loop research at the moment that people could get involved in?
Yeah, great. Thanks, Jim. And Liz mentioned this Be Part of Research. So even though at the moment we're not recruiting people with type 1 diabetes into closed loops systems in Oxford, adults anyway, there are other studies around the country which are either just opened or just about to open, which will be doing that. It's usually into subsections of populations. It may not be for everybody with type 1 diabetes. It might be for certain age groups, or it might be for people with certain ranges of HbA1c, or it might be for people who've had real problems with very low blood glucose. So research is often quite targeted, and that can be quite frustrating if you don't actually fit into that group, what we call the inclusion criteria. Sometimes it's about being patient. Sometimes it's just about agitating and saying, I want the study that includes me, and therefore what we have whenever we set up a study is we include people with diabetes to comment, to make sure we're not excluding people who might benefit from that research. And it's really important when you write a research proposal, you always must get somebody who has diabetes to comment on it so that they can give their opinion and make sure that nobody's excluded, or fewest people as possible excluded from the research. So quick answer is there's nothing at the moment here. The slightly longer answer is go to the Be Part of Research website, see if there's a study in another part of the country that you can get involved in. And then the slightly longer answer is be patient and keep agitating, and we'll get some more studies here in Oxford.
Liz, fundamental question, this one. Where do you think insulin resistance starts? You as a GP must see it in all its stages. Where do you think it starts?
So when we're talking about insulin resistance, we're talking about an imbalance in the amount of insulin, so the enzyme that helps us break down and process blood glucose, store blood glucose, an imbalance between producing enough insulin and our tissues, so the different parts of our body, responding to it. Some of the more recent research studies over the last, say, 5 or 10 years have shown us that we think that there's some really important organs in the body that may be where some of this insulin resistance starts, or some of the process starts. So if excess fat builds up in the liver, or the pancreas, so the organ that we know is producing insulin, this can affect the body's ability to produce enough insulin. We also know that the fat buildup in other tissues in the body can make it, and particularly the liver, can make them less sensitive, so less responsive to the insulin that we are producing. And that imbalance there is what leads to what we call insulin resistance. And that's an important part of the process, what we call the pathophysiology, so the way the body works in type 2 diabetes.
Rustam, it's a question here I think is a very specific question. And if you don't know the answer, don't worry, Liz might. It's a drug that's come through research, I would imagine. Can you say how effective the newer drugs like semaglutide are after stopping them? And does weight gain automatically resume?
Now that's really interesting, Jim. So what we're looking at here is when you do a trial, so when you're taking part in research, you look at what the average weight is, and you look at what the average weight loss is and what your average HbA1c is. What you don't know is, what does that mean for me as an individual? Because of course I might be the average person in that trial, but I might do even better, or I might not do quite as well. And so whenever you stop a drug, you're never quite sure if actually you're the really fortunate person that your weight will stay down, because what you've done is you've made lots and lots of maybe little or small or even slightly big adjustments to your lifestyle. You've changed some of your diet, you've changed the way in which you walk or get a bit of exercise. And actually those changes might keep your weight down, and they might be just as effective as the drug. But we do know from studies what we call crossover studies. So I take a drug and then I cross over and I stop taking the drug, and other people might not have taken the drug and they cross over and they start to take the drug. And that helps us understand the difference between taking the drug and not taking the drug. And certainly in crossover studies, it does appear that when you stop some of these drugs, weight does drift back on again. But I'd just like to emphasize for your questioner that actually that's an average weight, and that's across the whole trial. What we don't know is whether or not that'll happen for you as an individual.
So it's an interesting one, this, Liz, that you mentioned it right at the start, you know, the difference between type 1 diabetes and type 2 diabetes. They're almost different conditions. And weight is a much more fundamental part of type 2 than it is type 1, or have I got that wrong? Am I just generalizing wrongly on that?
No, I don't think you are, Jim. I think Rustam has talked here about the different stages that we think about of people's life and the development of diabetes. So we've got things that might put someone at risk of developing diabetes, then there's living with the diabetes, and things that might improve the condition for them. And we do know that weight in particular, so carrying excess weight, so living with overweight or obesity, is a really big what we call risk factor, so puts you at much higher risk of developing type 2 diabetes. Now that risk isn't the same there for people with type 1 diabetes, because as you've mentioned, it's an entirely different process within the body that leads people to developing type 1 versus type 2 diabetes. So you're right that we talk about it much more for people with type 2 diabetes there. But again, everyone is individual, and it's important for all of us, whether we live with diabetes or not, to be maintaining a weight that is healthy for ourselves and our body. So it's important for all of us.
Rustam, a question here which asks a fundamental question as well. Does high sugar intake invariably cause diabetes?
It's interesting, Jim, isn't it? Because if you were to do a research study where you would just give people some additional sugar and then try and work out, does everybody get diabetes? Probably the answer is no, actually, because we know that not everybody over a certain weight has diabetes. We might have friends or family who are overweight and don't have diabetes, and we have other friends and family who are not particularly overweight and do have diabetes. So just the giving extra sugar or taking extra sugar per se on its own doesn't always cause diabetes. Liz was just articulating really importantly there, when we look at research, we look at risk. So what is the risk of getting diabetes if I was to take additional sugar? And clearly that would be a higher risk than if I wasn't to take additional sugar. So often what we try and do in research studies is to tease out what are the most important risk factors, And then what can we do about them to try and reduce that? So it might be certain tablets or drugs that reduce the body's appetite, and so we don't want to eat as much sugar. Or it might be certain drugs and tablets that make our body pee out the blood sugars. And in recent years, those have been really effective. The research studies in those drugs have shown not just do people pee out the blood sugar, do they reduce their blood sugar in their body, they reduce weight, and also they seem to reduce the stress on their heart. And so they reduce the amount of heart attacks, and they reduce the problems with complications from diabetes. It's a rather convoluted way of answering the question, but it doesn't, essentially just eating sugar doesn't cause diabetes, but it increases the risk of diabetes.
This seminar tonight, webinar, is about research, and I'm very grateful to one of our attendees today who's done some serious research into closed loop systems for managing blood glucose levels, and whether there's any research going on at the moment. He's put it into there is a website where you can get onto a trial going on at the moment, and it's all in the in-call messages. So if you were keen on that one, just go into the in-call messages and you'll see it. This is an interesting sort of push on from that. Rustam, is smart insulin possible? By that, I think our questioner asks, is it possible to get an insulin that reacts to a person's blood sugar?
Oh, yes, great question, and absolutely. And some people sort of see this as being the ultimate insulin that you have. And so there's a lot of research being done. There's a big European consortium looking at encapsulating insulin, and you put the capsule under the skin, and then it's porous. So whenever the glucose goes in, it pushes some insulin out. And whenever the glucose is lower and it doesn't go in, then less insulin goes out. So definitely, yes, there is what you would call smart insulin research happening at the moment. I think everybody is excited about it, but also slightly nervous, like any good research, because you wonder about what the risks might be, what happens if there's another reason for that capsule to release the insulin, and clearly having too much insulin in the blood can also be very dangerous, as well as having too little insulin. And so like all these really good research studies, we start slowly and we gradually, methodically work our way through, making sure that we've got really good processes to take good care of the people who are very fortunately taking part in that research.
Liz, someone's reacted in the chat to that discussion we were talking about type 1 and type 2. They ask, is it too simplistic just to frame diabetes as type 1 or type 2? They say they drift in and out of type 2, but are not a typical of the type 2 type, by which I assume probably is to do with their weight and physical structure. What do you say to that?
I think the short answer there is probably yes. And actually research in recent years has started to think about, are there many more subtypes of diabetes? So we've been alluding to, if you say like the most common types that are commonly referred to, type 1 and type 2. And we do understand fairly well, I think, as people, patients and clinicians and as scientists, understand the ways that these two conditions are different, the way they develop, the people they affect, and how they affect our bodies. But actually there's been a lot of research saying, well, hang on, there's a lot of space in between these, and there's a lot of overlap, and people that we might once have labeled as clearly type 1 or type 2, much like this questioner, say actually, well, hang on, I fit in between the two. I think at the moment, what it comes down to is practicality, and it's working out what treatments and what support help that person the best, almost regardless of label. But I do think in the years to come, this research that has been going on and has been more prominent in the last few years of trying to really understand what puts people at risk of different sorts of diabetes, and how could we describe them different types in a way that really helps the person themselves and the people trying to treat them. I think that's really going to come to the fore in the next few years.
Rustam, I don't know if you've done any research on this, but good question here. Is fat as big an enemy as sugar?
Oh, interesting question, Jim. And there was a really good article by a number of scientists in London thinking about, is sugar the bad thing, or is fat the bad thing? I think it partly depends on the individual. And it might be that for some people, a high fat diet, which is very low in carbohydrates, helps them manage their diabetes because they don't get these spikes in blood glucose. And there's definitely some research around that. For other people, the research points to the fact that when they have that fat, it goes into, as Liz was talking about earlier, it goes into the wrong place. So that fat goes into the liver, or it goes into the pancreas, and it disrupts your ability of the liver to regulate your glucose, and it disrupts the pancreas in its production of insulin. So I'm going to sit on the fence, Jim, on this. And I think for some people, it's the sugar that's really harmful, and it makes their blood glucose really poor. And for other people, it's the fat, because it disrupts their internal organs.
But I guess there's also an underlying question there. Does research tend to go off in one direction and perhaps not realize there may be other things going on that we ought to be researching?
It's a good question. And you always start when you're doing research with what we call a hypothesis. And it's really, that's probably the most important thing, is to really tightly define your question. What is it that this study is going to try and answer? The temptation is to answer everything. You know, how do I cure diabetes? How do I stop insulin resistance? But narrowing the focus of your question enables your study to answer really important individual questions. And what we do, I think there's a phrase, is we stand on the shoulders of the people who are gone before us. We build on their work so that we can answer the next question for our generation, and then the people ahead of us can answer the next questions for their generation. So although it can sound a bit frustrating because you want to answer the big questions, sometimes you've got to just split the big questions up into smaller questions. And by doing so, then you can make sure that you've answered it really clearly, and you don't have to repeat those studies again. You mentioned there that you have to start with a proposition when you're doing the research. Question from the chat, how much the focus of research is driven by what patients want? Rustam. Yes. So I think increasingly would be the short answer to that one. And I think we would hold our hands up and said not enough in the past. It used to be that I had a great idea, so I will do the research study and people will come hopefully and take part in that. But increasingly now we have what's called public and patient involvement and engagement, and it's a really important part. And people with diabetes need to be involved, not just in commenting on the research study, but driving the priorities. And so the NIHR that Liz and you and I were talking about earlier, they have linked with a number of organizations to say, what are the key issues that people with diabetes want us to address? So Diabetes UK, NIHR, a number of bodies have come together and said, what are the top 10, what we call priorities for diabetes research? And that's been driven predominantly by people with diabetes, which I think is a fantastic achievement.
Liz, this is one, I think, for you. It's about another drug. Can you just highlight the pros and cons of metformin, which I think is a type 2 diabetes drug, isn't it?
It is, yes. So metformin is maybe one of the most widely used drugs, or certainly historically has been, for people with type 2 diabetes. And I think a lot of what we've been talking about is benefits and risks to individuals here. So metformin has been around for a long time. And so that means there's a lot of research over a large number of people in a large number of years that show that it is safe and broadly effective or beneficial, helps people with relatively few side effects. So it's fairly well tolerated. So I guess one of the main benefits is that we know quite a lot about it because it's been around a long time. It's widely available to a large number of people across a large number of healthcare settings. In terms of the cons, well, this will be very individual. Some people find it has really troublesome side effects for them, particularly, affecting their stomach, for example. And a potential con, you might say, looking now at the whole scope of type 2 diabetes management and treatment with all of the new drugs coming in, is that there are some newer drugs that maybe give people a bigger reduction in their blood glucose levels than maybe was possible when metformin first started. But I'd say, as with starting any drug or any treatment, it's always going to be down to a discussion between the person themselves and their doctor, looking at their individual case and saying, well, what I've described there are some of the very broad brushstrokes of maybe average responses, average benefits, and potential downsides. And actually what's really important is the person themselves that has diabetes speaking to their own clinician and working out, for my particular diabetes, for my particular health and my particular life, what would the benefits and risks or the upsides and downsides be for me.
Liz, that's a good lead off into this question, which is because research is often about drugs, isn't it? Research is about how we control diabetes through drugs, through insulin and so on. This question: how can I reduce my blood glucose levels with diet only?
Well, it's a great question, and it's something that was one of the things that my research is looking into here as well. Just to highlight again, we're talking particularly for people with type 2 diabetes here. While what we eat affects the blood sugar levels in every one of us, and in people with type 1 and type 2 diabetes, of course, at the moment, it's really important that people with type 1 diabetes don't try and control their blood glucose levels with diet alone, because they will still need to be using their insulin, as I'm sure every one of you knows. For people with type 2 diabetes, there's been a lot of research over recent years trying to understand what the best diet would be to help reduce blood glucose levels and maybe prevent the need for medication. Across a large number of research studies, working with a lot of people with diabetes, the short answer, I'm afraid, and while it might not feel like specific dietary advice to the person that asked it, is the best diet is the one that the person can stick to themselves. So across all of these tens of thousands of research studies, we've shown there are lots of different diets that have promise. So Rustam mentioned earlier, for some people, a low carbohydrate diet, so reducing those blood sugar spikes, can work really well. We know it's safe and effective in the short term for a lot of people with type 2 diabetes. There are some people who can stick to it brilliantly and find it's really effective for them, but there are other people for whom they really struggle. So when we say low carbohydrate diet, we're talking about cutting out sugary carbs, so that's sweets, biscuits, cakes, confectioneries, but also starchy carbs, so bread, pasta, potato, rice. And for some people, that style of diet just won't work for them. And if it's not possible to stick to it, it's no use at all. Other people find a lower fat diet, or what we call a low energy diet, so where they're just working on reducing their portion sizes, and the total amount of calories of energy going in is the thing that helps them to lose weight, and through that improve their blood glucose levels. So what I'd say is there's a large number of different dietary patterns. Unfortunately, at the moment, we've got no way of predicting which one diet is going to be the answer for the person in front of us. But we are working on a research study to try and help people, much like you try different treatments with drugs. If it doesn't give you the answer that you need, we don't say that drug treatment, that you've failed at that drug. We say that drug hasn't worked for you, and we move on to the next one. So we are working at a research study at the moment that's really designed to try and help people access and understand what dietary pattern is going to be the right one for them to control their blood glucose levels. So it's a work in progress to answer that question for that particular questioner, I'm afraid.
Rustam, I don't know if any of your researchers has come up with an answer to this, but we have a question here which asks, is there a link, or at least an increased likelihood, between having the sickle cell condition and developing diabetes? Do you know?
That's really interesting, Jim. I might have to come back to you on that one. I'm not aware of research. Now, when you think of sickle cell, you think of people who are a little bit more anemic, maybe, and there's different types of sickle cell. There's what we call a trait, which is a sort of mild form of the disease. As you know, it's a genetic disease, and you can have multiple mutations. One of the things we know that it affects is the red blood cell, and the red blood cell is very crucial to carrying glucose around, and you're all familiar with HbA1c. So certainly having sickle cell will affect your HbA1c. I'm not sure there's been much research around whether sickle cell actually causes or makes you more likely to have diabetes, or indeed makes your diabetes more difficult to control. It would certainly make it more difficult to measure how well you're doing, but maybe that goes back to the research I was talking about earlier of looking at the glucose in between two levels rather than necessarily looking at your HbA1c.
Well, two very specific questions that have come up in the chat. Can you be in more than one research group at a time? Are you restricted as a guinea pig? Rustam?
Traditionally, whenever you take part in a research study, it usually says, are you involved in another research study? And that's often an exclusion criteria. And the reason for that is, if you were to take part in a research study and say you're to give drug A, and then 2 months later you're taking part in another research study and you're to give drug B, and you didn't do really very well, would that be because of drug A or would that be because of drug B? And sometimes that can be a bit difficult, and so it can be frustrating because, you know, you're passionate about research and you want to be involved in lots of research studies, and then suddenly you can't because you're already part of one. What we're moving to now is, well, if I take part in a research study, which is maybe 3 or 4 or 5 years, but actually it's just surveying how I am and it's doing sort of normal types of measurements, but it's not actually giving me a drug, could I then take part in another research study that's giving me a particular drug or giving me a particular therapy or particular treatment? So increasingly, we're trying to become more nuanced rather than saying, if you're involved in any study, you can't take part. And now it's saying, well, actually, would that study in particular mean that you couldn't take part in another study?
Liz, there's a couple of questions that have come onto the chat that I'd just like to put to you. As research comes up with new drugs, how long does it take for that information to be communicated to GPs? And secondly, you've got a nice new drug that you think will really help a patient. How constrained are you by your budget, or can you just go out and prescribe the best new thing around?
So some really interesting several questions within there, Jim, I think. So the first question of how long does it take? I think there's 3 main phases of time that we're thinking about there. There's how long does it take the drug from discovery through all of the testing process, and that can be quite a long period of time. Once it's been proven or shown to be effective and beneficial and worthwhile to the patients, there's then a stage that again is preclinical, if you like, is before we can give it as a doctor on the ground. And that is where the pharma companies we've spoken about will work with the regulators in the UK to check its medical criteria and decide, is it going to be available in the NHS and at what cost? Once something has been approved, actually the processes are much more streamlined and it's much more available. So we've mentioned a bit about prescribing guidance here. So the NICE, National Institute of Care Excellence, makes recommendations to us as clinicians on the ground about what we can and should be doing for our patients, for example, with diabetes. And these knowledge summaries and management guidelines are updated periodically when there's been any new discoveries, or really every few years as a minimum. And these are the things that we as clinicians work off the evidence-based guidelines all the time. You mentioned, can we all prescribe the newest, fanciest thing? And, you know, I wish we could. If we were convinced about the safety data and convinced it would help every single person, then who wouldn't want to give that to everyone? The honest answer is there are still some constraints, and in each local area there is guidance. There's a set of rules made about what drugs can be used in what situations, and we are bound by them. But what I would say is that as the bodies of research evidence, as the evidence mounts for how beneficial something could be for a person, this really does help and does get translated into the guidance that comes out. So yes, it is still a bit area dependent, because regions and areas do make decisions about what drugs we can prescribe. But in terms of, you know, clinicians getting access to the information, I would say once they've been approved, you know, that is something that we as part of our continuing professional development will be referencing almost daily in the patients that we see, to make sure that we're practicing as up to date and giving people access to as much as we can that might benefit, or helping them to work out what might benefit them.
Area dependent, Liz, is that a euphemism for a postcode lottery?
That is unfortunately one way that people describe it, and I'm afraid if I could change that, I'd be a very popular person. Different areas of the country, what I would say is it's not an arbitrary decision, even though it feels really unfair. Different areas of the country have different populations. They have different ages of people. They have people with different health conditions, and there aren't infinite resources for everyone. So people across the country are going to be making difficult decisions about how can they do the most for the most people in their area, and that's what I think it comes down to. But I appreciate that doesn't change the frustration that we all feel as individual patients and individual clinicians, just wanting to be able to do as much as possible for the people in front of us.
We've got about 5 minutes left, Rustam. There's a question come up in the chat that I can really I know what he's talking about here, which is that different individuals have such different experiences. I can be happily going along with my blood sugar at 7 or 8 and it suddenly drops and there's no explanation for that. Someone else with type 1, it doesn't happen to them, and so on. Is there research into that, into why individuals have such different reactions to this condition, or are you always having to look at the general?
It's a great question, Jim. Thanks for raising that. And it comes to the heart of research itself, because of course, when we do studies, we want to know, is this applicable to just you, Jim, or is this treatment or whatever, is it applicable to everybody with type 1 diabetes? And increasingly what we're doing is we're trying to work out for the study population, who in particular has this drug or treatment been particularly effective for. So we might have a look at the whole population, and then we might say, well, actually, is it really important for or really effective for these particular individuals? You mentioned that the variability of glucose, and sometimes it goes up, sometimes it goes down, sometimes it stays the same. And there's no doubt that that is one of the biggest frustrations of people with diabetes. They do the same thing, they eat the same thing, and actually they seem to get a different blood sugar each time. I don't think there's any particular research into that, except what I would say is that the insulin trials that we've been involved in will often take account of that, because they're using some of this new sensor technology to see the variability in blood glucose. So it used to be that we would only measure something like an HbA1c, which wouldn't capture that sort of fluctuations in blood glucose. But now increasingly the trials are using those sensors to say, well, how much variability was there if I give this insulin compared to that insulin? And so I think we're starting to what you might call individualize or personalize that sort of research. And I think that gives us much greater understanding as to where it might be really helpful for some people, but maybe less helpful for others.
We're going to have to wind things up. I'm just going to ask a last question to Liz. You're a GP, you meet people all the time who have diabetes. What one thing would make the biggest difference in their life? What one thing would you like to be researched that is going to change their lives for the better?
Well, Jim, I think actually we've answered this question already. And the answer is that it's not me that should be saying. I'm not someone that lives with diabetes, and it's not me that should be dictating the research agenda. I personally, as a clinician, as a research scientist, of course, have things that my patients have asked that I wish I could answer. But I think the honest answer here is, we've mentioned patient and public involvement and engagement. I think the most important thing for diabetes research moving forward is engaging with people who are living with diabetes and listening to what they have to say about what they want answered. And all we can do is move forward from there and take that forward and do our very best for them to answer the questions that matter to them.
And Rustam, would you agree with that, or is there something in your mind that you would love to see?
No, completely. I think if this is going to work, if people are going to trust research, they need to feel that it's right for them. And Liz is absolutely right. We need to be doing the research that people with diabetes consider to be the most important. Completely concur with Liz's answer. Well,
thank you so much to Liz and Rustam, and thanks to everyone for providing your questions. I hope you found it insightful and informative. Thank you also to our host, the National Institute for Health and Care Research. If you want to learn more about research and how you can take part in studies, even if you're healthy, then as we've said in the seminar, search for Be Part of Research website. You'll all be sent a recording of tonight's event as well as an evaluation form. So please take a moment to complete it, because we want to run more of these events over time, so we want to know what we're getting right and what could be improved. I hope you've learned something from this. I certainly have. It just remains for me to thank you all again, and I hope you have a great evening for the rest of the evening. Thank you so much to Liz and Rustam.